We will continue the atrial section with atrial flutter and then atrial fib. Now, atrial flutter is caused by a single ectopic focus. An ectopic focus means it's coming from outside the normal focus, which means it's not coming from the sinus node. So this will be a single abnormal focus within the atria, and it's very irritated and it starts conducting the heart in a very rapid, repetitive fashion. The atria will start firing so fast that they are firing between 250 to 350 beats per minute. They're beating so fast that they cannot fully contract. They flutter. So our atria, normally when the sinus node fires and it depolarizes the atria, giving us that nice rounded normal sinus P wave, now our P wave, since it's coming from this atrial pathway very quickly, my P wave is going to have a sawtooth appearance. They're called F waves or flutter waves. Now, to protect the ventricles from receiving too many impulses, the AV node is going to block some of the impulses from being conducted to the ventricles. And that AV node can block the impulses in a regular pattern, or it can do it at random. Because the atria are fluttering so fast, you cannot accurately measure a PR interval. Now, I don't know if you remember when we talked about the functions of the AV node. We said normally the AV node can hold an impulse for about 0.08 seconds to actually allow the atria time to contract and finish filling the ventricles. The AV node plus the bundle of His can actually pace the heart. If for some reason the sinus node fails or the atria have been damaged, the AV junction area can kick in as a backup system. But the other thing our AV node can do is it can block out impulses. So when things are bombarding it, so if you're talking about the atria bombarding that AV node at 250 to 350 beats per minute, your ventricles would not be able to function at that. So the AV node blocking some of them is a protective mechanism. So in atrial flutter, it can be regular or irregular. We said the AV node can block things in a pattern, or it can block them at random. So R to R to R can be regular or irregular. My atrial rate is going to be 250 to 350 beats per minute. My ventricular rate is going to be slower than that because some of those impulses are blocked. Now I can actually count how many P waves I have. So here I see that I have more P waves, but instead of nice sinus P waves, they look more like a flutter or a sawtooth type of appearance to it. And so I can actually count how many flutter waves I have in 6 seconds and get a rate of 250, 350. But generally, when a doctor wants to know what is the rate of a patient, they want to know what the ventricular rate is. How fast are the ventricles having to work in response to it? So in this example here, I have QRS to QRS to QRS is regular. My rate, we're going to say this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7. So rate is 70. I see that my P waves have a sawtooth or flutter type of appearance to it. It almost looks like the top of a picket fence. Now, because of this, what happens is the flutter waves keep going even though the QRS is there. So you really can't measure an accurate PR interval measurement. And it's also going to skew your ST segment and T wave a little bit as well. So it's going to be hard to measure a QT interval or really look to see what the ST segment is doing. Really, the only measurement you can do with this one is the QRS itself. Your QRS should be a normal size unless you happen to have an underlying bundle branch block. It is abbreviated A flutter. The hospital I used to work at when I first became a nurse, we abbreviated atrial fib, capital A, capital F, and atrial flutter, capital A, little f. But when I started working at a hospital down here, they didn't do that. It was a fib and a flutter. They didn't make that classification. So you kind of have to follow your facility's policy. So in this example here, I have a regular rhythm, QRS to QRS to QRS is regular. My rate is 1, 2, 3, 4, 5, 6, 7. So a rate is 70. I see that I have more than one P wave than I do QRSs. And so then you have to ask yourself, are they nice, normal, rounded sinus P waves, or do they look like a picket fence? Are they a flutter appearance? And this looks just like the top of a picket fence. Now, as I mentioned, I can count how many P waves I have. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37. So 370. So I could say, yes, I have an atrial rate of 370, and my ventricular rate, though, is only 70. I don't need to do that. It really doesn't matter if that atrial rate is 250 or 300 or 350. It's too fast. How fast are the ventricles having to respond? That's really all we care about. I cannot measure a PR interval because I'm not seeing that hold in the AV node here. And I can't really measure QT interval because it skews my T wave as well. So really the only interval I could really look at is my QRS, and it does look normal there. So I would document this atrial flutter at 70. Now, this example here, my R to R is regular. My rate is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So my rate here is going to be 100. I see that I have more P waves than QRSs, but they have a really jagged edge to it. This is a really characteristic flutter wave where there are really these jagged edges. And this one here is generally taller because it's probably landing on top of the T. So I've got that the extra flutter wave landing with the T wave. So sometimes your flutter wave right where the T would be, it's going to be extra tall. One of the things you can do with this when you're looking at these and you're saying, okay, do I have a flutter wave here, or could this possibly be an SVT? Is just have your patient do a vagal maneuver. Have them bear down, have them cough forcefully, and it will slow the rhythm down, and when it slows down, the extra flutter waves will pop up. Here is an atrial flutter in a 12-lead ECG, and you can see in some leads the flutter waves are very distinct, and in other leads they are not. And so, sometimes when something different is happening with your patient, it's one of the reasons why we always say get a 12-lead ECG, because you can get more information that way and see things in different views and sometimes get a better picture. So here's atrial flutter. This is in lead 2. This is in a modified chest lead 1. Same rhythm. I've got an irregular rhythm for this one. So those other examples I looked at, R to R was regular, meaning that the flutter waves were dropping a beat at a very consistent pattern. Here, the flutter wave is letting this one go through, and then it's letting that one go through, and so the R to R is going to become irregular. So irregular R to R. My rate is 1, 2, 3, 4, 5, 6, 7, 8, 9. So rate of 90. I have more P waves than I have QRSs, but again, they have that kind of characteristic flutter type appearance. It sort of looks like the top of a picket fence. And so I'm going to look at that as atrial flutter at 90. Oh, sorry about that. I sort of forgot what my rate was there. I cannot measure my PR interval. I really can't measure an accurate QT interval. I can look at my PR interval, and it looks like it's only about 1.5 boxes. So that would be 0.06. So I would document this A flutter at 90. This one here, now this one looks regular. My rate is 1, 2, 3, 4, 5, 6. This one here doesn't land all the way in it, so rate is 60. I see that I have more P waves than I have QRSs, but these don't look like a nice normal rounded sinus P wave. They have that characteristic sawtooth appearance to it, or that picket fence look. Now you can say I have 1, 2, 3, 4 flutter waves to 1 QRS. 4 flutter waves to 1 QRS. So sometimes you might hear people refer to this as atrial flutter with a 4-to-1 block, meaning 4 P waves to 1 QRS. Whether you say I have atrial flutter with a 4-to-1 block, you would still have to say at a rate of 60. Or if I said I have atrial flutter at a rate of 60, it really isn't going to make a difference with this. This example here, It looks, by eyeballing it, it looks like it's regular. My rate is 1, 2, 3, 4, 5, 6, 7, so rate is 70. Again, I see that I have extra waveforms, but they have that characteristic picket fence look to it. And so it would be atrial flutter at 70. It has a very distinct look to it. I can't measure my PR interval. I can't measure my QT interval. My QRS, though, looks like it's about 2 boxes, maybe a hair over 2, and that's normal. This example here looks like an MCL lead. I've got actually it looks a little irregular over here. So an irregular rhythm. My rate is 1, 2, 3, 4, 5, 6, so a rate of 60. I see that I have more P waves, but they look like a sawtooth pattern, so it would be A flutter at 60. Now this example here is my rate's a little slower. It's irregular. R to R to R is irregular. My rate here is a rate of 50. I see that I have more P waves, but they look sawtooth. They look like they're going up and down. And it looks like I might also have a wide QRS, like maybe I had a little bit of a bundle branch block underneath it. If you have a rate less than 60, it is not an atrial flutter bradycardia. It's just A flutter at 50. And you can have a bundle branch block with any of your atrial rhythms. If you had a bundle branch block when they were sinus, you're going to have a bundle branch block now that they're atrial. Now, atrial flutter with a 2-to-1 block is when you have 2 flutter waves to 1 QRS, and it can be very hard to distinguish these from any other supraventricular tachycardia. It'll be a regular rhythm. R to R to R will be regular. Your rate's usually around 150. The waveforms will have a little bit more of a jagged edge to it, more of an F wave than that nice rounded solid P wave. If you think it might be an atrial flutter, have that patient do that vagal maneuver, and this should slow the rate down, and those extra flutter waves should pop up. So when I look here, it looks like I have maybe possibly some flutter waves, and then my rate starts picking up. R to R to R here is regular once it went into this fast rate, and I can see my rate is very quick. And when I look at this and looking, do I have a P and a T? Again, it looks kind of jagged here. Do I have a P wave and a T? Do I have a P sitting on a T? Is it an atrial P wave? Do I have atrial tach? Is it just flutter waves and they're going so fast, everything's blending together? So the best thing to do, have them bear down, have them cough forcefully. It slows it down just enough to pick up some extra flutter waves. And it's really very distinct when you do this. If it's atrial tach and you have them bear down, it will slow the rate down a little bit. If it's atrial flutter and you have them bear down, you'll see extra flutter waves pop up. So with atrial flutter, what can cause this to happen? Rheumatic heart disease, ischemia, hypertension, pulmonary disease. The significance of this is because the atria are fluttering, they are not contracting. So normally when your valves open up, so we said 70% of your ventricular filling is when the valves open up. It gets its other 30% when the atria actually contract. So after the atria have depolarized and they contract in response, that gives us our extra 30%. Well, now our atria are just doing this. They're fluttering. They're not fully contracting. So you might get another 5, even possibly 10% of filling down to the ventricles, but you're going to lose a good 20, possibly 25% of your cardiac output. So the symptoms are going to depend on the ventricular rate. If you lose 20 to 25% of your ventricular filling, most people can tolerate that pretty well. But if you lose 20 to 25% of your ventricular filling, and then in addition to it, your rate's really fast, that's going to compromise the person even more. So symptoms will depend on the ventricular rate. They may include palpitations, dyspnea, anxiety, hypotension, diaphoresis, and congestive heart failure. So our treatment, our first goal is generally to slow down the ventricular rate. That's our first thing we think about is, okay, if I have a rate of 150, so let's slow it down. And then I'm going to worry about getting it converted over to a sinus rhythm. We said those vagal maneuvers may increase the rate of block, allowing recognition of our flutter waves. The other thing we want to make sure we do before we start giving a lot of medications and treatments for this is we try to determine the onset of the atrial flutter as best as we can. If this person has been in atrial flutter longer than 48 hours, Our other problem is they might have developed blood clots. Remember, if your blood in your atria is not contracting all the way and pushing all the way down, and some of it's sitting inside of here, when blood sits, it pulls, it starts to coagulate. So if a person has been in atrial flutter for more than 48 hours, now we have to worry about the potential of blood clots. So we need to consider anticoagulation therapy for this person as well. Common medications that you'll see for atrial flutter: cardizem, verapamil, beta blockers, digoxin, amiodarone. We don't do adenosine. Adenosine actually doesn't work very well on atrial flutter and atrial fib. Now, if we don't know it's atrial flutter, because let's say it's that 2-to-1 block and it's so fast we can't really tell, is it atrial flutter, is it atrial tach, is it just an SVT, we may end up giving adenosine for it. But it doesn't usually work well for atrial flutters and atrial fibs. So if you know you have atrial flutter, you know you have that, then we would give a different medication. It is generally very responsive to cardioversion. So if your patient is stable, we have time to try medications. If they are unstable, we are going to cardiovert. And remember, we said cardioversion is a synchronized defibrillation. They have to be hooked up to the leads of the machine. They have to have the patches on. And when we turn on our defibrillator and we set our energy selection, we also have to hit the sync button. We want this to fire on the QRS complex, not on that downslope of the T wave, which can make things even worse. Because our patient is in an atrial flutter, and it is usually so responsive to cardioversion, we can usually start off with less joules. 50 or 100 joules is a lot of times enough for an atrial flutter for cardioversion. Overdrive pacing, again, overdrive pacing is when we turn the pacemaker up higher than what the rate is for the patient, and we let the pacemaker take over as pacing the heart, and then we start turning it down, hoping that broke the cycle and the SA node can kick back in. We do not do overdrive pacing with external defibrillators. We can use transvenous pacemakers for that, and even permanent pacemakers if there's someone there who could reprogram it.